Asia. I'm going to talk about the impact of COVID-19 on clinical practice in AFCON countries. These are the contents of my talk. We will quickly review the current scenario of COVID-19 in Asia-Oceania regions, the general impacts of COVID-19, and in particular, the impact on medical physics, clinical practice. This is the current statistics extracted from the WHO database. As of 20th November 2020, we have total cases of 56 million around the world. The total death has reached 1.3 million. As of Asia-Oceania regions, the total cases has reached 11 million, and the total death was about 174,000. So how bad the scenario is? This diagram shows the death tolls of multiple pandemics in human history. Let's look at COVID-19 in March 2020. The number of deaths was about 4,700. But in just 8 months' time, the total death has reached 1.3 million now, and it is ranked after the Asian flu. If you look at number of deaths by cause in the world in 2017, the top result of death was cardiovascular diseases, which has claimed about 80 million lives. COVID-19, being a new virus, has placed itself among the few top results of deaths in the world in just 12 months' time. As medical physicists, we are familiar with this basic principle of radiation protection, time, shielding, and distance. And now, due to the pandemic, everybody is practicing the similar principle, so-called as new normal. For example, we limit the time and number of patients visiting a hospital. Everybody is wearing a mask, and we keep a physical distance between each other to reduce the risk of infections. Now let's look at the impact on clinical practice in radiotherapy and brachytherapy. Oncological patients are at higher risk of infection due to they have compromised immune system as a result of both cancer and active cancer treatment. There are higher ratio of cancer patients in the elderly group, which is a high risk of COVID-19. There are also frequent visitors to hospital due to hyperfractionated radiotherapy or chemotherapy. A recent report found that cancer patients in China with COVID-19 had a 3.5 times higher risk of mechanical ventilation, ICU admission, and death compared with those without the disease. So, our patient might ask, should I continue my cancer treatment during the COVID-19 pandemic? What would be your answer? According to the American Society of Clinical Oncology, there is no direct evidence to support changing or withholding critical anti-cancer treatments in patients. The justification are, stopping treatment may enhance tumor progressions and shorten survival time. Delayed chemo radiotherapy might not be any safer to resume should they reschedule it for the coming weeks or months. And what's more, it's unclear now how long the pandemic will last. We have seen some changes in cancer care management. Of course, they are implemented with clinical justification. For example, in some systemic therapies, it can be replaced by alternative dosing schedules. Some infusional therapies can be replaced by equivalent oral oncolytics formulation if available. For continuous infusions or growth factor support or hormone therapy, it can be considered to administer at home with the home care nursing service. We also seen some inpatient chemotherapy shifted to outpatient setting. And for certain type of cancers, hypofractionated radiotherapy can be considered. For restaging scans, the time interval between scans might be increased or replaced by the use of biochemical tests. I would like to highlight the practice of hypofractionated radiotherapy. This is not a new idea at all. Multiple clinical trials have been done. One of the large clinical trials is named CHIP trial on prostate cancer patients that involved 3,260 men from 71 centers in UK for a 5 years follow-up. The studies found that hypofractionated radiotherapy using 60 gray in 20 fractions is non-inferior to conventional RT using 74 gray in 37 fractions and is recommended as a new standard of care for EBRT of localized prostate cancer. The data was published in 2016 in The Lancet Oncology. And a more recent study was called Fast Forward trial on breast cancer. 4,096 patients involved from 97 centers in UK, also 5 years follow-up. The study concluded that hypofractionated radiotherapy using 26 gray in 5 fractions over 1 week is non-inferior to conventional RT using 40 gray in 15 fractions over 3 weeks and is as safe in terms of normal tissue effects up to 5 years for patients who are prescribed with adjuvant RT after surgery for early stage breast cancer. For patient safety, we have implemented new guidelines, including pre-screening and screening for COVID-19 symptoms and exposure history via phone or digital platforms. Develop screening clinics to allow for patients with symptoms to be evaluated and tested in a dedicated unit with dedicated staff. Convert in-person visits to telemedicine whenever possible. Institute limited or no visitor policy. Limit surgeries and procedures to only essential, urgent or emergent cases. Consider alternative dosing schedule or hypofractionated radiotherapy wherever possible. Provide resources for wellness and stress management for patients as well as their family members. As for healthcare workers, we also have new SOP implemented to assure appropriate PPE are worn to the guidelines. Most hospitals have implemented duty on rotation basis. This could be morning and night shift or alternative working day or week from home. Implement daily screening tool and temperature checks. Telecommunicate whenever possible. Establish clear stay-at-home and return-to-work guidelines. And importantly, to provide resources for wellness and stress management for the staff as well as their family members. And also to create a centralized resource or website to communicate, as guidelines around the PPE and workforce might change according to scenario. If you want to read more about the technical guidelines, you can visit our AirForm website. Next, we move on to nuclear medicine. These are according to the IAA's guidelines. Before arrival for the test, we screen patients by history on the phone. We prepare triage for COVID-19 risk assessment and also postpone the non-urgent cases. On arrival for the test, all the healthcare professionals must wear the PPE. We screen patients by history again, consider temperature screening, and also we separate patients by a certain distance and minimize the number of attendants in the department. We review test indications again. During the test, minimize contact for written consent or consider verbal consent. Preferentially use rapid protocols whenever possible. Preferentially use vasodilator stress or avoid exercise stress during the cardiac test. The rooms or the equipment must be handled per local infection control policies. After the test, we avoid sharing computers and sanitize keyboards. Use telehealth wherever possible for image interpretation and reporting. Use telehealth wherever possible to discuss results with teams. And also review lung findings on hybrid SPECT or PET-CT to identify if there's any COVID-19 patients. You can read more from these IAA publications together with European Association of Nuclear Medicine, ISRRT, and the World Federation of Nuclear Medicine Biology. In these guidelines, it also listed the priority cases. It's categorized to 3 categories. Priority 1 are the cases to be maintained as scheduled. Priority 2 include cases that can consider postponing, and priority 3, mostly the cases can be postponed. These include bone scan for non-oncology findings, lymphocintigraphy, MIBG for heart, labeled pellets, thyroid, parathyroid scan, HIDA scan, as well as SPECT and PET for neurological diseases. There's also a publication on an international survey in April 2020 on the global impact of COVID-19 on nuclear medicine departments. There were 434 responses from 72 countries. In overall, the number of cases of nuclear medicine diagnostics and therapies have reduced by 20 to 60%. Among all, South Korea and Singapore are the countries who are least affected. Now let's look at the impact on diagnostic radiology. Imaging should not be utilized for screening COVID-19. RT-PCR test is the primary screening tool. Chest radiography will likely to continue to increase as the pandemic continues. Chest X-ray is often the only imaging test performed in the evaluation of COVID-19 and is used more frequently than CT. Chest CT may be used to guide management in complex scenario and clinical deterioration. All imaging suites and equipment must undergo terminal cleaning and disinfection after each scanning of suspected COVID-19 patients. Portable imaging is preferred wherever possible. Glass evaluation occupies COVID-19 patient. I'd like to share with you a study by Brachy et al. From Melbourne, Australia. The team has evaluated the technique, radiation dose and image quality of portable chest X-ray done through the glass of isolation rooms. This is the standard protocol for a portable chest X-ray, and this is the protocol for the true glass technique. The KB used was between 90 to 120, MAS between 1.4 to 12.5, depending on HVL and the distance. The most frequently used protocols are 105 to 110 kbp, 4.5 and to 5 ms. As a general rule, for every additional 2 meters, MAS might increase by 4 times, and for every 3 meters, MAS increased by 5 times. The team also evaluated the scattered achroma on the radiographers inside and outside the room. As you can see, at 1 meter from the glass, the scattered dose received by radiographers are quite comparable. And the main findings are, the percentage transmission of X-ray is 41 to 49% for 90 to 120 kVp, and it's also depending on the glass. The scattered achroma is about 0.25 microgram per MAS at forward directions at 1 meter away. The image quality and effective dose are comparable to the conventional method. The first image shows a good example of portable chest X-ray on the COVID-19 patients through glass technique. However, positioning of patients and the X-ray tube might be challenging due to space constraint. For example, in the second image here, the top apex of the patients are cut off. In modern machines, EI is a very important parameter to detect radiation reaching the detector related to image quality. In this study, you can see the EI is slightly higher than the standard. This is easily understood because it's a new technique, new protocol, and more studies are needed to optimize the radiation dose and image quality. For interventional radiology, for image-guided procedures in COVID-19 positive or suspected patients, full PPE must be worn by all the attending staff. Referent departments must ensure that all papers sent to radiology must be handled by staff with donning gloves. The papers must be contamination-free. Patients who require diagnostic biopsies via aerosol-producing procedures such as endoscopies, endoscopic ultrasounds, or bronchoscopies may undergo CT-guided biopsies if possible. Molecular testing and liquid biopsy might also be considered. In summary, COVID-19 has hit us hard, but we do not compromise patient safety and health at any time. Standard clinical care is carried out as usual with extra precautions for patients and worker safety. As evidence, our work performance and patient outcomes are optimized and surprisingly becomes even more efficient in certain occasions. The medical physics professional activities have shot up a lot, as we can see many free webinars are being organized by multiple organizations in the past few months. But the main pitfall to our medical physics profession is actually the mental stress of getting infected. And in fact, that is not our worst worry. Our worst worry is, if we get infected, we might infect our family members. Medical physicists as a health professional. This is the theme of this year's IDMP. Through solidarity, we will overcome. We have been through 20 years of teamwork under the umbrella of AirForm and CFORM, and surely, together, we will go through this crisis and move towards a brighter future together. Here shows the photos of our medical physicists colleagues around the world. I would really like to take this opportunity to thank everyone who has contributed to our profession. Thank you very much and wish you all the best.